Uh-oh. Okay, got it. Oh, now my slides aren't moving. Oh, there we go. Okay, first of all, I want to talk about the pioneers in this field, Dr. John Lee and Dr. Katarina Dalton. Why I want to speak about them specifically is partially because of the diametric differences in their philosophies. So, Dr. John Lee wrote this book, Natural Progesterone. As he retired from his practice towards the end of his years, he took the work of Dr. Ray Peat, who was a physiologist and biochemist who studied progesterone directly. So Dr. John Lee used progesterone in his practice and reported positive results for 100 patients in the treatment of osteoporosis for those patients. He wrote this book, which I think if you've never looked at it, it's a very good primer on progesterone and its activities. So Dr. Lee had a couple things that he was quite adamant about. One was that your body produced no more than 20 milligrams of progesterone. So that ought to be your dose, which is confounded by when you put hormones into your body, unless you're directly injecting it, you only absorb a portion of that dose. You don't absorb the whole thing. So if you were really low in progesterone and used 20 milligrams, you could very well, depending on the cream base, absorb maybe 1 milligram, something very, very small. He also was a strong proponent of saliva testing. And one of the things we know about saliva testing, when you are administering a topical progesterone, those results are going to be sky high on saliva. The companies that offer saliva testing will give you a normal range for untreated people for hormones, but then they'll also give you a second higher range for treated to evaluate those who are treated. And where does that higher range come from? This is not a scientific concept. This is something that's made up by the lab, partially to accommodate the fact that those levels in the saliva are going way up, but it's not correlating with clinical response. So let's move on here. So he defined estrogen dominance. He is credited with giving us this definition. And basically, your estrogen can be deficient, it can be normal, it can be high, but that it's the ratio between the estrogen and the progesterone that makes you have more estrogen symptoms to the point of a lot of discomfort and a lot of chronic problems. Talking about that 20 milligrams, I decided to do a deep dive on his 20 milligram issue. And I looked all over the place and tried to find original research that said 20 milligrams was produced by the human body. And I finally emailed Dr. Ray Peat, and he said, for one thing, if you check the output in the uterine vein, you get 100 milligrams. His supposition that 20 milligrams is somehow an upper limit for progesterone is rather faulty. So prior to Dr. John Lee, now we have, this book was published in the 50s, but she published some of her research sooner, Dr. Katarina Dalton. And she is the woman who first characterized PMS. And not only did she characterize the symptoms of PMS, she developed treatment, which was progesterone. And Progesterone was used in very generous doses. She started out with injectable. As I mentioned before, that's going to be completely usable. She eventually switched over to suppositories, and the suppository doses would be something like 400 to 600 milligrams. Suppositories applied vaginally or applied rectally. So her doses were considerable. So the work of Katarina Dalton was the basis of what was happening at Women's International Pharmacy. We embraced the work of Katarina Dalton, and Joel Hargrove and Wayne Maxon, along with a compounding pharmacist, devised a oral progesterone in oil and demonstrated that you could get appreciable blood levels, you could get luteal phase blood levels if you used at least 400 milligrams a day. What was interesting about this is now we're using some really, really large doses of progesterone. And in those PMS patients, we dealt with some severe symptoms. We dealt with suicidal tendencies. We dealt with huge headaches. One of the things we found was the starting dose with those oral encapsulations were 400 milligrams a day, divided doses. But sometimes that wasn't enough, in which case women used more. And we even developed other dosage forms. We developed suppositories, we developed lozenges, rectal solutions, creams, gels, what have you, to get to a place where progesterone could handle all of the symptoms of PMS, not just some. Here's a little schematic where Dr. Dalton was trying to point out that progesterone receptors are all over the body. And here we are quite a lot of years later, where I think this needs revision. We have progesterone receptors all over the place, and needs to be taken into consideration when you're thinking about how much progesterone does somebody need to make to reach a point of comfort. I want to bring this up too, and probably everybody here is familiar with this graph, this stylized graph. What's the problem with this, and it's often the case, is that the units of the hormones are not demonstrated. So we have estradiol, but these levels of estradiol are in picograms per mil, and progesterone's in nanograms per mil, 1,000 times higher. So imagine, if you will, that curve for progesterone is 1,000 times the estrogen. One of the big things here that I think is often overlooked is in the follicular phase. That progesterone primarily comes from the adrenal glands, and it's not a flat near zero line. It has substance. When you multiply that line times 1,000, you'll see you're way beyond the amount of estradiol being produced. Just to verify that, I just pulled some lab ranges for the labs, just to reinforce that progesterone's in nanograms over picograms for estradiol. This is really important. So I think that graph has minimized the importance of progesterone in many people's minds. So when we have estrogen excess, we have all these symptoms. These are a few common ones: headaches, breast tenderness, leg cramps, gallstones, fibroids, vaginal bleeding. There are 700,000 hysterectomies done per year in the United States. A good major proportion of those hysterectomies are performed for excessive vaginal bleeding. So this is a pretty dramatic thing. So after working with Women's International Pharmacy, I no longer had this direct patient contact that I had so many patients teach me. So I decided to go to Facebook, and Facebook is where you're going to find your failures. There are support groups all over the place. You'll find many, many women and men who have gone to doctor after doctor after doctor with this kind of constellation of symptoms and have been unable to find relief. So I'm going to present a case. And this is PMDD. And the history of PMDD is very interesting. And I have a paper documenting some of that. But in the late 90s, Prozac was running out of their patent protection. And they were seeking to have a new indication for their drug. And they put together a study and showed that women had some improvement with their mood symptoms during the luteal phase. They were essentially capturing or trying to capture those severe PMSers, as Dr. Katarina Dalton had already characterized, and move this into another treatment plan. At the time this was happening, I thought, well, this isn't going to go anywhere because progesterone works so well. But to my surprise, I found that this alternative treatment is entrenched in conventional medicine. So this is what those women with severe PMS or PMDD, premenopausal dysphoric disorder, are being faced with. First, they're put on SSRIs, and that doesn't work very well. Then they'll get put on birth control pills, then gonadotropin blocking agents to wipe out all your hormones. And incidentally, when they do that, they give you back estrogen. And then when that fails as well, they decide to relieve you of your organs. So you'll have a complete hysterectomy and oophorectomy. So these women are being told that they are sensitive to progesterone and they should avoid it at all costs. And so a woman with this diagnosis has gone all the way through this, and yet she still has those symptoms driven by that extra estrogen she's being given, and they will be on a cluster of drugs. They're suicidal, anxious, angry, tender breasts, insomnia, weight gain, and they use a lot of drugs. They're using benzos, they're using antidepressants, they can't sleep, all signs of too much estrogen and certainly not enough progesterone because they're being denied their progesterone. So on one of these Facebook pages, the Estrogen Dominant Support Group, they are talking about an interesting phenomenon they call the estrogen kickback. And this occurs when the dose of progesterone is given and all symptoms, it seems, of estrogen are increased. Now, John Lee did recognize this way back when, and he said at a conference when women were taking Progest and experiencing exactly that, they couldn't stand the small 16 milligrams of progesterone, and they would be anxious and panicky, can't sleep. And Dr. Lee said, oh, well, no matter. You just continue to take that dose, and by 9 months, it will have disappeared. From the Katarina Dalton point of view, we can make those symptoms disappear very quickly. We called it breakthrough. We had breakthrough symptoms. And if you give more progesterone and give it right away, even every 15 minutes, whatever it is you have, you can entirely flip those symptoms. And this continues to be a real problem with using progesterone. Too many doctors are being trained to use too little progesterone. They make their patients worse. The patients leave. They have no sense that they are creating some real problems. These patients become convinced that they cannot use progesterone. So one of the things I think about when you're faced with these estrogen dominant symptoms and you're using progesterone, progesterone has so much work to do. John Lee also said that progesterone stimulates estrogen receptors for estrogen, and that was causing what they are calling the estrogen kickback. However, when I look this up, I find little evidence for this actually happening, nothing strong that I could give you. And I don't know if some of this estrogen balance is because of receptor activity, or is it some sort of yin-yang situation that the activity is in opposite directions and somehow balance each other out. It's a real conundrum, not strong evidence that I've been able to find. Then progesterone is an immediate precursor to hydrocortisone. So what happens if you are low in hydrocortisone? That you've had either an acute big stress or chronic long-term stress and your hydrocortisone is simply low. Does progesterone fill it in? I would imagine it is, but there are people that argue that somehow pregnenolone is diverted to make more hydrocortisone, somehow leaving progesterone out of the equation. I don't know if that's true or not, but I do know that when you use progesterone, you may help the adrenals with the hydrocortisone, or you may help the adrenals simply on the basis that progesterone is an adrenal hormone. And as I said before, in the follicular phase, it's no small amount of progesterone, it's a large amount. Progesterone, along with pregnenolone, is synthesized in the Schwann cells. All the nervous system in tissue in your body are subjected to this production of pregnenolone and progesterone and used right there. We're never going to see those levels on any lab tests. They're used up immediately. The nice thing that happens is that if you use progesterone exogenously, you can get some results with nerve cells. I was at a conference, it was a pharmacy conference, and I spoke to one of the speakers later in the day at a reception, and he told me during his presentation, he was afraid he might fall over because he could not feel his feet. And I gave him some progesterone to rub on his feet for the night. And he came back in the morning and he said, "What have you done to me?" That dose of progesterone allowed him to feel his feet again. His only complaint was that it wore off, but you do have to use more. I myself was astonished too at the rapidity of this particular intervention for him. So progesterone and all of the neurosteroids are made de novo in the brain from cholesterol. There's a whole independent hormone factory going on up there. Fortunately, these hormones do cross the blood-brain barrier. Again, if you use it exogenally, it will make a difference, particularly to mood things. Headaches are easily remedied with progesterone. Progesterone is an aromatase inhibitor and a 5-alpha reductase inhibitor. We'll go into that a little bit. Mast cells. We're talking about mast cell activation syndrome all of a sudden, and what a big problem this is. So I immediately go to the literature and see how hormones are involved. Well, guess what? There is estrogen dominance happening in mast cells when there's histamine released. Progesterone is a hormone which has an antihistamine activity. It keeps that excessive estrogen in check inside the mast cells. We have, particularly after menopause, we have intracrinology inside the cells. There is a whole hormone factory, and this is what we're dependent on, particularly postmenopausal. And progesterone, even though its structure doesn't predict it, is a strong antioxidant. So here are some of the other problems contributing to this estrogen dominance issue. Methylation deficiencies. We got more attention being paid to our ability to methylate, which is a detoxification process. And interesting enough, both estrogens and adrenaline require methylation for detoxification. We have recirculation of our own hormones. When we have a disordered microbiome that produces beta-glucuronidase, that enzyme will cleave off a conjugated estrogen and put it right back into circulation. So you can have a buildup of your own estrogens. Your own factory keeps recycling and building up. Xenoestrogens, outside sources, insecticides, pesticides, many of which have been documented to have estrogen activity. Metalloestrogens is the class of estrogen-like activity produced by heavy metals such as mercury. Then we have, later we'll talk about this a little more, fungus, candida. Some organisms produce 17-beta estradiol. Endometriosis, this growth of uterine endometrial type tissue outside the uterus, was thought by the candida people that endometriosis has a strong link to being caused by this fungal overgrowth. Glyphosate has estrogenic activity. So if you're tending to be a vegetarian, look out for the glyphosate in your plant food. If you're a meat eater, some of the animals are implanted with hormones deliberately to make them grow faster. And they are estrogens and androgens like testosterone and synthetics, and can be 17-beta estradiol. So it's in your food. So I want to introduce you to Dr. Pleckner, Dr. Al Pleckner. He was a vet, and he's written a number of articles and books. And he discovered by looking at total estrogens versus IgG, IgM, IgA, and beta cells, the immune cells would be all of those molecules would be low, with total estrogens high. And some believe that total estrogens are just a reflection of estradiol and estrone. Dr. Pleckner felt that there were also some other estrogens contributing to this load of estrogen, and he thought they were coming from the adrenal glands. I've talked to lab people. I can't get good information on what all that total estrogen lab result tells you. But what Dr. Pleckner found, when you had this high total estrogen with the very low immune molecules, that hydrocortisone could be used to treat. And he was very successful in treating a chronic disease in dogs that caused blindness. He also treated, so-called treated, about 2,000 humans because he felt environmental issues were a strong cause of this imbalance, and where the pet was, the human was, and he could find analogous situations in humans. And by treating with hydrocortisone, you could just completely change the situation. I would submit, but he never did, that perhaps progesterone would also work. We don't know. Dr. Pleckner's passed away now. Very interesting ideas, and he's written a lot, which is still available. So now we have Dr. Platt, who's written a very interesting book called Adrenaline Dominance. And we have a whole number of symptoms that are associated with high adrenaline. So one of the things I started to wonder about the so-called estrogen kickback situation with using low progesterone, there was also a component of heart palpitations, panic, women running to the emergency room with low doses of progesterone. And I started to think that these symptoms sounded more like adrenaline than they sounded like estrogen. And I think this estrogen kickback picture is bigger than just the estrogen. I think there's this adrenaline component. Now, adrenaline is in charge of keeping your blood glucose normal. And when you drop into a hypoglycemic state, your adrenaline will go up. It may take cortisol up with it, or it may not. If you're not able to make more of the corticosteroids, it may not bring it up too. But anyway, you have the adrenaline. Now we have the situation where there are many of us, and they think as much as 40% have methylation issues. So you have this high adrenaline surge, but you may not be able to get rid of it very easily. So then what? One of the problems that many face is good sleep. And I believe it was Melvin Page. He was one of the endocrinologist dentists from around the 1930s who had wonderful endocrine insights. And this was called liver insomnia. And what happened is, if you would wake at, say, 3 or 4 o'clock in the morning and not be able to go back to sleep, your mind was busy and you just couldn't settle and rest. If this was going on, Dr. Page advised that you put an apple by your bedside and eat an apple, because your blood glucose was down, adrenaline was up, and while this adrenaline was high because it was trying to get more glucose to your brain, you would not be able to sleep. And sure enough, if you give patients that advice and they eat an apple, they can fall right back asleep. If this is what's going on, it further points to the liver not being able to store enough glycogen for the night. So there's not only the adrenaline issue, there's a liver issue that should be looked at if this is what's happening. Here's a slide. Here's a study. Glyphosate directly impacts the alpha receptors for estrogen, which is the stronger. This is where estradiol is attracted. So it has a strong influence on estrogen type activity. Here is an article about the Schwann cells, as I was mentioning before. Pregnenolone and progesterone are produced independently, not really measurable, but do help this situation, which nerve tissue is not getting enough progesterone. I'm throwing this in because I didn't mention it earlier, but I came across this with my theory about you can look up just about everything and ask yourself, what's the hormone connection? And sure enough, with COVID-19, reverses hypoxia, stabilizes blood pressure, controls thrombosis, balances electrolytes, reduces viral load, regulation of immune responses. This is quite dramatic. There's also studies published that I've seen with hydrocortisone being particularly low in those post-COVID, long COVID, vaccine-damaged people. So this close correlation with hydrocortisone and progesterone is probably a key, something to look at and measure if this is going on. Here's the mast cell secretion. As I mentioned before, I found a whole cluster of articles. If you have this imbalance inside the mast cell, degranulation is going to occur more often, leaving you with histamine release and histamine symptoms. So I just wanted to point out a few symptoms that are associated with hormone problems, which we have asthma and allergies, hot flashes, perimenopausal symptoms, anxiety, bloating, recurrent migraines and dizziness, insomnia. One of my clients said to me, she's getting stomach aches. Well, we know there's a lot of histamine receptors in the stomach. We have H2 blocker drugs like Tagamet. Interesting. So are you looking for stomach aches for a hormone disorder? Here's another complication with sex hormone binding globulin. And I put this in here because I think we should pay attention. We have many hypotheses in this field of hormones, and they don't all hold up all the time. And here's one. We've been pretty much taught, don't even look at sex hormone binding and total hormones because that's not available to the cells. But there is a study to show that there's a protein shuttle, megalin, that will bring the whole complex, the bound hormone with sex hormone binding globulin, right into the cell. Here's a little graphic for it. So you can't discount this carrier protein, which can be bringing in more estrogen, more testosterone than you really realize into the cell. Okay, 5-alpha reductase. As I said, progesterone will be a 5-alpha reductase inhibitor. And this is a theory about how it works. Progesterone also is acted upon with 5-alpha reductase, and it offers alternative substrate to testosterone. So that's how its action might be. Could be others, we don't know. And I just wanted to point out one finasteride, Prozac, Propecia. Look how close it looks to the progesterone molecule. So I submit to you, why are we submitting people to toxic drugs like finasteride? There are lawsuits going on with young men with trying to treat their hair balding, and they lose all sexual interests, they're depressed, they're suicidal, where you could be using progesterone, which is the hormone inside that should be working inside our body and doing that exact activity. So I want to spend some time on Candida because this causes all sorts of problems when you're trying to use progesterone. I think I saw this in John Trobige's book, The Yeast Syndrome, that Candida will flourish in the presence of extra progesterone, testosterone, hydrocortisone. And this is indeed my experience. When I was working at Women's International, we had really good results with progesterone, but there would be women who didn't have good results. And I finally tried to sort this out. Why was this happening? And one of the biggest issues that I discovered was underlying candida overgrowth. So when you get all these other symptoms, if you take a look at some of these things, you'll also see that. So when you have somebody that you've identified as being imbalanced with too much estrogen effect, and you want to use progesterone, and you get these signs of candida overgrowth showing up, something to pay attention to. My suggestion is that you get on top of the candida first, give patients the ability to control that candida overgrowth, and then use the hormones, maybe a little bit more cautiously than otherwise, maybe pregnenolone as the first choice rather than progesterone or some other techniques. So I just want to show that there are so many of interesting different symptoms when candida is part of the picture. Things on your skin. I'm always looking for Dr. William Crook, who wrote The Yeast Syndrome and the Yeast Syndrome of the Woman. I had a personal conversation with him, and he said one of the problems that candida produces is mycotoxins are being excreted through your skin and your vaginal tissue. If you have any burning and itching symptoms, always think candida. Well, that might take you to your doctor's office, but when they look for a yeast infection in the vaginal tissue, there's no yeast infection. It's not the yeast, it's a mycotoxin coming from the overgrowth that's seated in the gut. So we should be looking for, in the case of PMS, we should be looking for underlying candida overgrowth. And endometriosis is not on this list. I would put that there too. A lot of postnasal drip. Chronic sinus infections are considered to be fungal in nature. Sometimes people get mistreated with antibiotics, it makes it worse. Emotional issues are big with candida. And then here's a big problem with fluid retention, weight gain. There's a lot of complaints with perimenopause and menopause with weight gain after having eaten the same you've eaten for years, had stable weight, and all of a sudden you're out of control. This is one of the places to look. But excessive estrogen can also be a problem just all by itself. Here's more of the itching, stuffy nose. Glass of wine causes, here's another estrogen excess that I didn't do a slide for, but after one glass of wine, your estradiol level can just shoot right up, creating instability. And I just put this in as a reference. There used to be a group called the Candida Research Group, and this was a public group, and the exec collected all these articles and gave it to me, and they were different organisms and what the excuse me, I'll just, I can't do it. What the organisms that these what things the hormonal effect of each of these organisms, and here's the references. I just put this in here as having some references so people have some appreciation. I after this original thing, I updated it some years ago, but there's a strong evidence of all this organisms, and sometimes organisms that don't belong there are creating hormonal issues. There are organisms that can bind 17-beta estradiol. There are organisms that can create 17-beta estradiol. Okay. Okay, as an aromatase inhibitor, I think this idea of, okay, we use some testosterone, and testosterone's too much is aromatized to estrogen, and that's the problem with estrogen dominance. You want the testosterone activity, but you want to stop too much estrogen. We're kind of forgetting that aromatase is increased when you have excessive glucocorticoid activity. That may be your underlying problem that you should take a look at. But progesterone is also a moderator of aromatase and should be considered rather than a pharma drug as an alternative. And here's an interesting paper. As a antioxidant, increases antioxidant enzymes such as SOD. I found this vastly interesting. In this particular paper, they talked about progesterone being a possibility for a lot of eye disorders, macular degeneration, retinal pigmentosa even. Quite interesting. I mentioned Ray Peat before, and he was a very prolific writer. He wrote about 4 books, and he had a newsletter, well referenced and well thought out. I took his newsletter for years, and would always make my brain hurt because I had to reframe what I thought I knew, and if this set with what I knew or if it didn't. But one of the things I'd like to point out here is vitamin E. I have another slide. I think it spares progesterone. Back where we have the candida problem, why not add some vitamin E to this situation? And there's another thing that Ray Peat rather brought up, and it's being taken up by some of the people in the Facebook groups, that prolactin could be a measure of tissue estrogen. Prolactin will go up and does go up in the presence of excess estrogen, in the presence of hypothyroidism. So this can be treated with progesterone. If this is the case, progesterone will bring down prolactin. Vitamin E will bring down prolactin. This is an interesting thought. We're taught that estrogen is needed for the bones. Under this particular pathway, with its increase in prolactin, excess estrogen could have a negative effect on your bone turnover. Here's the vitamin E. Dr. Peat also liked aspirin for this. And then back to endocrinology. From circulating DHEA inside the cell, we have the whole hormone factory going on. And this also can be dysregulated. But we can also use exogenous hormones to help correct it. Okay, so back to our case study. So what do we do with this woman who has been diagnosed with PMDD? And she doesn't even want to take progesterone. She took 100 milligrams once at bedtime, and she thought she was going to die. She had terrific panic attacks. She went to the hospital, had all her cardiovascular stuff checked out, and was told there's nothing wrong with her. But she somehow knows now that she is sensitive, or progesterone doesn't sit well with her. In this case, somehow we have to get rid of that fear. And I put a dose range, as I mentioned before, with the severe PMSers. We started on 400 milligrams daily in divided doses, and I've seen women as high as 2,500 milligrams. And this can be in one dosage form, various dosage forms. I think creams are sometimes a problem. The hormone, progesterone hormone, is suspended in a cream. It's not completely dissolved. So you have these particulate matter in that cream. And in order to get past the skin barrier, a couple things have to happen. It has to be dissolved. You have to have skin oils to dissolve that particulate, the rest of it. And you have to have good circulation to the skin. So if you happen to have a hypothyroid patient, both of these things are missing. Skin circulation is poor. There's not enough oils. You can have patients report they get white powder sitting on their skin. Well, that's not gone in. Doesn't matter how much you think you've given. So oral progesterone can be good. Some proportion of women make allopregnanolone with it, and this causes a lot of drowsiness, equivalent to the drowsiness you can expect from phenobarb. I think this has been responsible for the recommendation by doctors all the time to take progesterone at bedtime. Now, progesterone can be a precursor to the allo, or it can be simply relaxing your mind, making it possible for you to sleep. And I think that's tied up into the balancing of adrenaline that progesterone can do. So you can use vaginally. It's very good absorption. Rectal is good absorption. You can use alternatives when there's too much drowsiness from progesterone. You can do that. So given what's some of the other things I've talked about, stabilizing insulin and glucose and identifying food sensitivities, because you can have a glycemic response to proteins if you're sensitive to it. There's a pathway for that. So you want to look at that first. Insulin, glucose are your most primitive hormones, your strongest hormones. And I believe with this large incidence of insulin resistance in our population that we're seeing more and more of this. Another little pearl I heard from a colleague was she had a client who was using a continuous glucose monitor. And when she had a hot flash, her glucose monitor would give her a reading of 50. Quite a dramatic drop. So something to think about for these what we normally attribute to estrogen rising or falling or whatever. Methylation groups, you can use methylated Bs, you can use betaine, SAM-E, but you need the methylation groups for detoxification, as well as sulfur, the glutathione and sulforaphane and NAC. You need sulfur for conjugating estrogens. Remove heavy metals, as I mentioned before. This is also a source of estrogenic activity by activating the estrogen receptor. Use antihistamines. Now, some of the literature will say, use Zyrtec and use Tagamet as antihistamines. I would say, remember vitamin C here. Vitamin C is a strong antihistamine. And of course, progesterone, as we've just said, we're going to give her lots of it. Vitamin E, because it spares the progesterone. Maybe you can get by on less. Sauna for the xenoestrogens. Decrease the supplemental estrogen. You may have these patients, you've had a hysterectomy, they come to you on estrogen. When you add progesterone, as I said, that estrogen activity is intensified by whatever mechanism it really is. John Lee, this was a good piece of information, I thought, recommended that you half the amount of estrogen being used when you introduce progesterone. what do I have down here? I can't see. Okay, salt to help your adrenals, along with vitamin C, B5, enzymes for immune complexes that could be giving you issues from food sensitivities. You can break this down with enzymes, proteolytic enzymes. Use candida protocols. And this is a conundrum for me. There are so many techniques that have been developed to treat candida. I do not know what the best is. Fiber. Dr. Pete recommends a daily carrot salad, shredded carrot with vinegar and coconut oil. And then just the other day, I heard an interesting thing about ozone. I was in a medical office, and they have ozone treatments, and they had within their disclaimer that ozone could help detoxify adrenaline. And this was being given to a young man who had POTS. And I tried to find something down that rabbit hole. What I found only was that in the case of low cellular oxygen, adrenaline and estradiol are not metabolized very well. So there might be a place for ozone in this complex patient. I'd like to report just today, I had a follow-up appointment with a woman from the Netherlands that I've been in contact with for about a month. And she is one of these PMDDers. She's fortunately got her organs, but she's been drugged. And she's been able to start decreasing her antidepressant. She is off her proton pump inhibitor, so she can absorb her food better. I asked her if she's been treated with like retin-A for rosacea. Said your stomach acid will be taking care of that now that you're supplementing with digestive enzymes. Anyway, her mood in this period since I saw her 2 weeks ago, she's tremendously excited. She's like 60 to 70% better. She's not 100%, but that's what she wants. She said, now that I've come this far, she said, I want it all. This is a woman, when I first talked to her, didn't think life was worth living. I want to point out a couple of things. I think there's a progesterone conspiracy going on. In the United Kingdom, family practice doctors can prescribe no more than 200 milligrams of progesterone. And something similar in the Netherlands. They can go up to 400 milligrams. But when they're prescribing more, they're already subject to somebody questioning their practice. So this is a problem for these particular patients. And I pointed out like a extreme case, but this is it's a continuum. Some women might do just fine on 50 milligrams progesterone or 100 or 200, but there are many that need a lot more. So this is my hierarchy of hormones, as I mentioned before. Insulin, glucose, you've got to look at that. So many people just test the sex hormones there at the bottom. Adrenal hormones, corticosteroids. We don't have a test for adrenaline. However, Dr. Platt says, do a morning cortisol. And if it's above, a fasting morning cortisol, if it's above 11.5, consider that adrenaline's right up there, and it's a hyperadrenaline situation. Thyroid will not work well if you don't have the adrenal base for it. If your adrenals are insufficient and you try to use thyroid, you'll get heart palpitations and intolerance. And then finally, look at the sex hormones. So this is a sunrise over Bocan Baru in Panama near Boquete. It's pretty cold morning up there on the mountain, but I love this group and what people are trying to do here, trying to look at what we know and try to engage our colleagues and find out who knows what and what pearls we can apply to the people we're trying to help. So right at the last, I have my contact information. And I'd like everybody here to consider going to A4M's forum there at the bottom. Forum.worldhealth.net will take you right there. Please participate. And I'll try to get this lecture posted there, and love to have your input on that particular case. If you have ideas and other things you've seen in your own practice, I'd love to see it. So that's it. Thank you.
Hi, Carol. This is Dr. Patel.
Hi.
Lecture. How are you?
Thank you. Good, good.
It's excellent, excellent.
Thank you very much. I appreciate that coming from you.
Yeah.
What do you suggest for the women? We start on the HRT on progesterone, and then they start having a little bits of bleeding. What do you say to these patients?
Okay, here's another possible myth. Progesterone is a hormone that makes the endometrium secretory. So if you start progesterone and there's a buildup, when you have enough progesterone available to work, it's going to shed it. It's a wonderful thing. Better out than in. People, back to the graph where I had the menstrual cycle, and we've all been taught this, that you don't have bleeding until estradiol and progesterone drop. And my experience with working with the PMSers, they could be as regular as clockwork, and they would have severe symptoms 1, 2, 3 days into bleeding. And the advice was stay on your high dose of progesterone. Well, guess what? They bled right on time, no drop in progesterone. So this is a conundrum. People have in their minds that progesterone has to drop to bleed. But when you put progesterone in and it creates a secretory endometrium, you're going to get rid of it. And that's a good thing. Warn your patients.
So how long would they bleed then?
I think the function of how long they would bleed has something to do with how much progesterone you've given them. So if they are like spotting on whatever dose you've given them, they could continue spotting for a long time. If this is coming up, use a larger dose. Get the buildup taken care of. If somebody has been progesterone deficient for a long time and you're starting progesterone, let them know they could have a large bleed. Could be quite substantial for that first bleed. If you stop the progesterone, the bleeding can stop, but you still have the endometrial lining still stuck and enlarged.
Carol, what about for patients who you give progesterone, just progesterone itself, and then suddenly they have reactions? And these are various when I see them patients. They get sick, dizzy. Is that related to the progesterone, or more of the imbalance because they were not given estrogen as well?
Okay, as I showed on several things, it can be it can be this estrogen kickback. It can be how the progesterone is metabolized. I have a blog on my website when women don't like progesterone, and there's numerous reasons I put together and something to investigate. The biggest reason that they do have problems with progesterone is underdosing. Probably the next biggest is candida. issues. So when you're talking about dizziness, brain fog, I'd look for candida.
Yeah, I have this precise patient that has recurrent candida vaginitis, and I gave her a bit of progesterone, and she felt so dizzy and vertiginous she couldn't tolerate it, and so we stopped it. But interesting, candida, huh?
Yeah. So I would, like I said for this patient, and I did say it once, try pregnenolone instead. Has less impact, probably on the blood sugar issues. There's also suppression of some of the immune components with progesterone, and that allows a woman to carry an alien fetus. That same suppression, immune system suppression, like a pregnancy, can also not recognize or allow the candida to flourish. That's the only two reasons I've found with progesterone allowing that candida to flourish. There may be more, but those are the only two I found.
Are you in favor of doing antifungals for candida, or you rather do this naturally?
What can you repeat a little bit
Oh,
louder?
are you in favor of doing antifungals for candida, or you rather treat this naturally?
You're talking about probiotics and diet.
Yeah. Mhm.
Yeah, and well, kill the candida with short chain fatty acids or oregano, garlic. I can't really say what works. Dr. Morton Teach treats candida excessively in New York City, and what he uses is nystatin in every orifice, a lot of it. He said he's the biggest prescriber of nystatin in the US, and he's gotten some results. Some people say if you have heavy metals, unless you take care of the heavy metal problem, you're always going to have a candida problem. I've heard arguments on both sides of that, so it might be something to look into as well. But you do have to do something so your patient can manage that. Once they are on hormones, particularly testosterone, testosterone is needed for every protein synthesis in your body, every single protein, and it will strengthen your immune system. So something also to look at. It has an impact on candida flourishing too, but much less than the progesterone does.
What was the name of your website again?
It's the Wellness by Design Project.
Okay, thank you.
So, Carol, don't you think then that may be a good idea when there's a question about, big question about problem with candida? One can use progesterone to see that it makes patient worse?
Yeah, as a diagnostic. Yeah,
Absolutely, it is a diagnostic.
it totally will. It will.
When in doubt.
Yeah.
When in doubt.
Yeah, and the biggest symptoms tend to be gastrointestinal changes, whether it's constipation or diarrhea, and the head stuff, the brain fog, and the sinus stuff really pop up really quickly.
And there may be also anxious, depressed,
Yes,
right?
yes, yeah.
Right, right. So what about that progesterone which is over the counter?
Okay, for the most like Progest, which I mentioned before, 16 milligrams per dose, Proganol, 30 milligrams per dose. For many, these doses are much too small. There are a number of companies out there, I've got them on my website, that have over-the-counter products, 50 milligrams per dose, 75 milligrams, 100 milligrams per dose, 200 milligrams per dose. Quicksilver Scientific has smaller doses, but it's exceptionally well absorbed. So you have a lot of over-the-counter opportunities for progesterone. Now, as I mentioned, UK and Netherlands, they don't have this available. These women are desperately trying to get products from the US to help boost up their ability to have more progesterone. Just quite appalling.
Can you make a comment as a pharmacist for my patients who want to get their progesterone commercially because their insurance might cover it? Can you discuss a little bit the difference that you could get maybe at Walgreens versus maybe some of the compounded progesterones?
Okay, so there are it's blown out of my mind. There's a vaginal progesterone that's FDA approved commercially. I think it's 50 milligrams or 75 milligram dose. And then your choice is the capsules, Prometrium and generic. So with compounding, you have all sorts of options. Now, everything is all the same molecules, the bioidentical hormones, whether it's an FDA product, it's a compounded product, it's an over-the-counter product. It has to be. This is all in the regulation of the FDA as far as a pure and clean drug supply to the country. That's part of its basic functioning, which I think is a good thing. So compounding, you get the options of dosage variability. You can do creams, gels, you can do suppositories, all sorts of lozenges, all sorts of different dosage forms. And you're going to find, like I mentioned with the creams, if you had a hypothyroid person, the cream might not be your best. The gel might be better because the progesterone is already dissolved if you have a clear gel. Or you might want to do a vaginal suppository. You might want to insert a capsule vaginally. All sorts of opportunities. The really wonder about compounding is it's endless what you can do with those options.
But a couple times I prescribed progesterone at the Walgreens, but then what the patient shows me in the office is something called a medroxyprogesterone. Can you describe what this is?
Well, that's a serious mistake.
Yeah. It's not what I ordered, but that's what we got.
Oh my God. So it's a synthetic analog, and it's been quite popular. And it would be interesting to have a side-by-side comparison. One of the interesting things about medroxyprogesterone acetate is it's water soluble. It's not fat soluble, but think about the implications for that in your body as your body compartmentalizes different things. But it does help shed uterine lining, yes. Although it might not be as efficient as progesterone. I've heard of cases women had been on that, started progesterone, all of a sudden have a really heavy bleed because it simply wasn't working well enough. But many of the progesterone activities that I put up there that you would really like to have, the antihistamine, antioxidant, aromatase inhibitor, the synthetic medroxyprogesterone acetate does not do that, or it doesn't do all those positive things. So that was the progestin used in the Women's Health Initiative. It actually is demonstrated, even before that study, has been demonstrated as being stroke-inducing. It's rather a dangerous thing to be using. I think it should be off the market, but it still persists.
One of the things that we teach in AFRM, just in response to Stefan's, progesterone in your regular CVS or pharmacy usually are noted to be short-acting types of progesterone. So when we're talking about sleep induction, that's a big factor. And when, I mean, not all, but when you do a compounded version of progesterone, it's usually E4M, or extended release. And this is something that we usually use for the ones who like sustained sleep in terms of waking up in the middle of the night. But for the initiation of sleep, the Prometrium is a more, useful product, and also it's covered by insurance for patients. So it's just more accessible compared to the compounded progesterone. And this is oral that I'm pertaining to.
Right. Many years ago at Women's, we did a PK study with our progesterone in oil, and we compared it to somebody. It was a compounded timed release tablet. Somebody was compounding. We compared it to that. And what we saw was they both dropped off at about 6 hours. And the area under the curve for the time release was less than the capsule in oil. So we saw no reason to do the timed release. So when you're using the timed release formulation, do you know what sort of blood levels you're getting with that? Have you checked? Just curious.
Yeah, no, well, most of the time we use urine testing
Okay.
in relation to levels. So we look at the allopregnanolone. So I see a lot of my patients really bumping that allopregnanolone up higher with the oral progesterone. I mean,
Yep.
you mentioned about the vaginal and also the
Yep, exactly.
right.
Yeah,
So yes, right. So I don't have a number, but we usually have that. I'm sure you know Dutch. So that the gauge there usually kind of shows that effect for us. And Carol, you just mentioned a while ago, you said that when patients are bleeding, you bump the progesterone higher rather than, because the tendency is the clinicians would stop everything until the bleeding stops. But you're saying let the bleeding stop, then increase the progesterone, or increase the progesterone while they're bleeding?
You have that option to increase while they're bleeding. It's already started the process of shedding. And if you want to get a more efficient shed, you'd go up. And definitely, as I mentioned, if you stop, you're going to stop that process. You're not going to be bleeding, but the overgrown endometrium still is there. So if you want to speed it up, if your dose of progesterone is lower, you might not bleed as heavily, but it'll take longer to get rid of it. So you have an extended bleed.
So when you add it a little bit more, you're going to hasten the process, and then for the longer term of things, you're not going to have bleeding at all, right?
Right. Once that happens, now you know your endometrium is cleared and you're ground zero, whatever your therapy is going to be then, if you're going to cycle or a steady state, you at least have, you know that. Then you have a situation, let's say you were using some estradiol and progesterone every day, whatever dosage form, everything's hunky-dory, and all of a sudden there's bleeding, spotting. What's going on? So what's happened, if you ask, and this has been my experience like 100% of the time, ask for some sort of stress sometime just prior to this bleeding incident, whether it's going on vacation or if, often I hear some really dreadful family situations. During this time, here's where the pregnenolone steal or simply progesterone converting to cortisol to deal with the stress. When that's happening, there's no longer enough progesterone to balance estrogen. Estrogen becomes stimulant, builds up a layer, and then after a period when the stress has dissipated, progesterone will make that layer secretory and cause some bleeding. That's the spotting, and that's a fairly common thing that can happen. You can go for years and then all of a sudden have some spotting. So always look for a stress just prior, and then by the time spotting's occurring, the problem's corrected itself. And you could do the same thing. You could use a little more, make sure you get rid of all the endometrial tissue that's built up. You can just let it continue till it's finished, whatever you want.
Carol, do you have any idea about when the young girls, they stop their period under stress and then 2 years and have no period? Usually the GYN will put them on the birth control pills and they don't feel good. So how would you approach that?
Well, this is really interesting. Have you heard of Dr. Jerry Lynn Pryor at University of British Columbia? She's studied osteoporosis. She's studied cycling. She's got a wonderful website, Semcor, CEMCOI.ca. A lot of information, a lot of what she's been studying. But highly athletic women, first they lose progesterone, and then they even lose estrogen. So what are you going to do with them? You could, the first thing you should do is always use progesterone first to replenish the progesterone and then bolster estrogen activity for whatever estrogen you have. Sports competition is a big drain on the adrenal glands. So using progesterone in that case, you could, in the case of young girls, you could set up a cycling situation where you use some progesterone month long, but you use a larger amount for the luteal phase. So it really depends on what kind of stress they're continuously experiencing. But in my experience with dealing with younger women with PMS, when I first started, I thought PMS would be forever. And it wasn't, because I started talking to many women who said, I used to get progesterone for PMS and everything cleared up. So I stopped. And now that I'm perimenopausal age, those same symptoms are coming back. So I surmise that using progesterone and cycling progesterone was able to give the pituitaries the signals that they could correct, LH, FSH could correct, and they had normal cycles. So what I would recommend is try to reestablish a normal cycle with the natural hormones.
Carol, are you familiar with there's a group out there that's when they use hormone therapy in postmenopausal women, they use high doses and they make them bleed.
Yeah.
And it's perceived by this group as actually a good sign. And even I heard some of these meetings and patients were raving about having menstruation at 70 just because of these high doses of hormones. I don't know if what are your thoughts on that?
Yeah, it's really quite interesting. I did an N of 1 study for 3 months myself to see what it felt like. And I was experiencing some weight gain, which I didn't like. However, you go up to like a dose of 16 milligrams of estradiol, and it feels wonderful, actually. So I can see that. And they do also accordingly, they do some very high doses of progesterone. So the question is, for long term, is that a good natural situation? I would say yes and no. What's his name? Don Colbert has written, I never met him, but he's written a number of books. I've read several of his books. And he had been using hormone therapies in his practice, bioidentical, for many years. And one of his later books, he said he started using hormones in larger amounts, but not in the amounts that we're talking about, Wiley protocol, which I think is really high. But he said, like for himself, for example, testosterone, he was using testosterone supplemental and felt pretty good, but he bumped it up so he would be on the higher end of the range. And he said, my decades of psoriasis just disappeared. And he started giving his patients more generous dosing of the hormones than he had previously, and was reporting some really excellent results. It's a very interesting book. And I think that he's got a good point. Like, where is the optimal for this? Okay, so you sleep better and no hot flashes. You're comfortable, you deal with stress okay. Is that your optimal point, or could you be even better? So I think the Wiley protocol would say you could be better. I don't know. Suzanne Summers embraced the Wiley protocol. And I know for a fact that she had a hysterectomy because of heavy endometrial buildup. Now, this made no sense to me because she should have been working with people who knew how to deal with that and help her shed that. So it's weird to me that that happened. So I don't know, but definitely some high doses. At Women's International Pharmacy, by the way, the highest dose of estradiol we ever dispensed was 50 milligrams per gram in a cream. And this woman, fortunately, worked for a physician's office, and they could test her all the time. It wasn't until she got to that level that she had, first of all, a blood level, and second of all, she felt okay. Later, I theorized that maybe she had some overgrowth of one of the fungal things that binds estradiol, or maybe it was poor absorption with the cream. I don't know, but that was the dose where she finally felt good. Well, normally doctors wouldn't even entertain that kind of dosing, but she was able to get it because of her situation.
Yeah, they sometimes don't absorb transdermally. You can get injectable estradiol cypionate from TaylorMade Pharmacy. That works pretty well.
Yeah, when you're doing an injectable, you're ensured that the absorption is there. I mean, yeah, it's completely absorbed.
Hey, Carol, if I may ask, what's your diet? What do you eat?
Me.
As a volunteer with Dr. Clearfield, I that's all I hear is hormones all the time.
Uh-huh.
And I think food is huge. Stefan's done some excellent classes with red meat, and I've gone back and forth. Really curious what you think.
Okay, that's another place I've been delving into stuff for a long time. I'd like to just point out for the PMSers, the PMDDers, the perimenopausal women, Katarina Dalton recognized the hypoglycemic nature of what they were doing.
Right.
And she recommended eating every 3 hours, which now we don't usually do that. We're more inclined to restrict carbohydrates, do more fats and proteins. This woman I was consulting with today, I first did recommend her to eat every 3 hours, and it made a tremendous difference to her. And then I said, send me your food diary. And she's already hypothyroid. Her tests are low. And I said, let's see what progesterone will do for your thyroid. It might bring it back up before we make a change there. But her diet was full of nuts and seeds and wheat and yogurt. And I said, quite a lot of what you're doing is thyroid suppressant. I'd like you to be more Paleolithic. And that helped her improve even further, which I think is really positive. I like the idea of being metabolically versatile, that you're able to go to fat burning to glucose burning pretty easily. Your body can be resilient. I just heard somebody sent me a video about how important protein is, particularly the first meal of the day. Like you should have about 1 gram of protein per pound of ideal body weight, but at least 30 grams at breakfast, and then all kinds of positive documented stuff on triglycerides and insulin, glucose. Just that one thing, having sufficient protein at breakfast. And what are people eating? Oatmeal. Oatmeal and toast and a piece of fruit. So I went to a low carb USA meeting, and I was totally impressed with many of the presenters at this meeting were some of the fittest people I've ever seen on a stage presenting. And some interesting things like their LDL, these marathoners, good shape people.
Right.
LDL was sky high, like 800. So we're trying to suppress LDL.
Yeah.
Why? Do we really know what we're doing? We don't. We don't have a clue. So I personally bounce around from trying to be keto, doing some fasting, like pretty much I tend to eat 2 meals a day. I really don't want to snack. I also avoid eating at night because I was able to interview Jamie Kaufman, the chronic cough enigma. She says, you're coughing at night, you've got postnasal drip, and it's actually a form of acid reflux that you're getting from eating too soon and going to bed too soon. So you're getting that backed up and it's making you cough. And sure enough, if you wait at least 5 hours, it goes away.
Yeah.
So that's the important piece.
I do my best to work with as many veterans as possible. And a lot of us have insomnia. It's like across the board, most all of us. And I've got this new acupuncturist that I've been working with. And she got me onto this new book, Heal Your Metabolism. I think it was 2015, 2017. And when I wake up in the middle of the night, the 1 to 3 time frame, she wants me to get up and eat a little bit of protein and a little bit of food. And it's kind of worked a little bit. It's been pretty amazing. I'll be honest, because I don't eat at night either. I try to eat before 4 or before 5, but now I'm kind of sneaking in some stuff and it seems to be working. It's kind of amazing, to be honest.
That book is inspired by Ray Peat's work.
Yes, it is. Exactly. Agree.
And he eats the carrot salad. He allows orange juice and Coca-Cola with cane sugar. He said you do need carbohydrates.
Right. Some, yeah.
So
excellent.
I have heard some people report, there's a forum, a Ray Peat forum.
Right.
Some people have done amazingly well with following his guidelines. Some people not.
Right. Thank you so much.
Oh, thank you.
And we do, let's see. And we do have one question in the chat. What is the ideal ratio of estrogen to progesterone?
You know what? I have a mental block against thinking about ratios, because one thing you know about hormones, they're never the same. If you took a blood draw 5 minutes later, it's not going to be the same.
Right.
I would say sufficient to have no symptoms. That's the ratio you need to be at. Enough progesterone or other aids to balance any excess estrogen. My idea for treating people is use progesterone, use it liberally, and get to a point of comfort, and then take that patient through the process. Like, where is all this estrogen stimulation coming from? Do we need detoxification? Do we need to clear up the teeth? Do we need to change the microbiome? There's so many things that can be causing the problem, but let's do it from a point of comfort rather than misery.
Carol, are you comfortable seeing cancer patients with PR positive receptors and being used on with progesterone by clinicians? I have seen it before. I just don't know if in your experience you saw that.
So you're asking if it's PR positive, if you should use progesterone or restrict it?
Yeah, because I have seen clinicians do it regardless of positivity or negativity on the receptor. And the premise there is they always know that progesterone is always negating estrogen and also, of course, being more protective in relation to the hyper effects of estrogen. I don't know if you've seen that in your practice.
and it's got an effect on the P17 gene, which encourages apoptosis. I'd like to point out, if you look up progesterone in breast cancer, for instance, you can find studies that show that progesterone has a negative effect, actually allows the breast cancer to grow more. And I would say in the case of fibroids as well, if you underdose progesterone, you could get this estrogen kickback phenomenon that I was speaking about earlier and actually make the situation worse. So I think you need, if you're going to do it, don't do it timidly, do plenty of it. There are also are studies to show that if you are progesterone receptor positive, progesterone is more, this was John Lee way back when, he said progesterone is more likely to work. And in general, women have a more positive outcome if that indeed is the case. There was some interesting stuff done with endometrial cancer. I think it was at the University of California, San Diego. They noted with endometrial cancer, and we used to treat endometrial cancer with progesterone with quite a large success rate, as it turns out in their abstract, and they had studies. But what they were looking at were progesterone receptors, and they noted that as the cancer worsened, the number of receptors declined. And what they were proposing to do was to have a test for progesterone receptors, and that would tell you how bad the cancer has gotten or how bad it is when you first stage it. I found that a really interesting concept about the diminishment of the receptors, and wonder if it's not got an analogous situation in breast cancer, but I don't know.
Okay, just in case Dr. Halasa's knocked out, he made myself co-host and a lot of other co-hosts. So is there any other questions, or does anybody have anything else for Carol Petersen? I think it was an excellent class, and I know Dr. Clearfield would definitely approve of it. He's probably not about himself. Honest. So thank you for the class. Someone recorded it. I'm hoping it was Shell Stein, and if he did, he does have access and he knows how to send it via email. It was you?
Yep, I got it.
Yes, excellent.
Yeah.
Okay, so if anybody
Really
wants to
good.
Shell's a person to get a hold of.
Yeah, we'll find the right place to post it.
Thank you, Shell. Appreciate it. All right, and I think with that, we'll probably end the Zoom.
Thank you.